and welcome all to the latest ECIST podcast. My name is Elaine Goodwin. I work in the ECIST team. I'm a nurse by background, and today I'm delighted that we have Sarah and Shelagh to come and talk to us about virtual wards. Sarah and Shelagh, do you want to introduce yourselves, and also if you could just summarise how you got involved with virtual wards, what set you on this journey? Shelagh, do you want to start?
Yeah, hi everyone. I'm Shelagh O'Riordan. I'm a consultant community geriatrician. I worked in hospitals for years, but in 2016 I moved out into the community. And at that stage we weren't running virtual wards, but when COVID hit, we had a large community team that were doing proactive work, and it didn't seem like a particularly good idea to carry on doing that. And we basically changed our team into being a what I called at the time a hospital at home for people living with frailty, and since that time then that name has sort of slightly morphed into being a frailty hospital at home virtual ward. So I work in East Kent, and we have a large team we see about 2,500 to 3,000 patients a year, all of whom or many of whom would have been in hospital otherwise. Over to you, Sarah.
Okay, so I'm Sarah Sibley. I'm a consultant respiratory physician at Liverpool Heart and Chest Hospital, and like Shelagh, I've been working in community in a community respiratory team since probably 2012. Our team were commissioned to sort of improve respiratory health for our local population, but also provide early supported discharge and admission avoidance services to try and help to support patients with a wide range of respiratory conditions in their own home where possible. So when the COVID pandemic hit, we started supporting patients with acute COVID infection in the community as well. And then the new phrase of virtual wards was coined really during COVID. And I think the real strength that it brought to our team was that we started to really use technology and using telehealth to monitor patients in their own home, so that people could be monitored more closely than we'd done previously, and also require potentially less face-to-face visits as part of their care. So really, we've been doing this kind of for many years, but we've now really brought technology into the mixture and are starting to really push the boundaries, I think, of what can be delivered outside of a hospital setting.
Brilliant, thank you both. And I think you both touched on this a little bit, but I just wondered if you could share with us what your view is on the purpose of a virtual ward.
Shall I start?
Go on.
So I think that for people living with frailty, I think of it as an alternative. I don't think of it as a replacement to hospital. I don't think it is for inappropriate admissions to hospital. The people that, a virtual ward is by definition providing care at home for people who would otherwise be in hospital. So you're providing hospital level care. And I think of it as a choice. You're really sick. You're sick enough to go to hospital. Do you want this treatment at home, or do you want to have that treatment in hospital? So I think of it as a choice rather than you must have it here, or you must have it there, or you're not sick enough for this so you can have this, or you're too sick so you have to go there. So I think in the world that I work in, if the patient wants to have their treatment at home, no matter how sick they are and they understand that, or their family do in acting on their behalf, then we will provide that care at home. So that's how I think of it.
Yeah, and respiratory patients, can get very ill very quickly, but a lot of people with respiratory conditions have been living with those conditions for a long time and are familiar with becoming unwell and potentially being admitted to hospital. And, I've been working in community respiratory for 10 years, and I often hear that people don't want to go to hospital for their care because they've been many times. They feel that we could be providing some of that treatment for them in their own home, where they're surrounded by familiar people, the people they care about, and also sort of in a familiar environment. And this offers us an opportunity really to do what people want us to do and give them the care that they want in their own home, and allow them to be more involved in making choices about their care. So I think this ability to monitor people closely at home has opened up the doors of options for people.
It's brilliant to hear that about that emphasis on opportunity and choice. And I suppose it's that personalised care agenda, isn't it, about what matters to me? And I wondered, just expanding on that, what is and what isn't a virtual ward? So how does that look from a clinical point of view?
Yeah, so maybe I'll start on this one, Sheila, if that's okay.
I was going to say
that. I think in respiratory, we have lots of patients that are being monitored from in a long-term condition perspective. So they're being monitored to check that their health is stable and to help them identify worsening. So that's not a virtual ward, but that's really good sort of preventative and proactive care. I think where virtual wards become really relevant is when somebody becomes acutely unwell and there's a consideration of whether hospital care might be the right place for them to receive their treatment. And so if somebody is acutely unwell, hospital admission is being considered where somebody would receive treatment in a physical hospital bed, then I think a virtual ward is a good alternative if we could safely and effectively provide the treatments at home that you would give in hospital. So you need treatment to be given, monitoring, but it's for really unwell people for a short period of time.
And in the context of frailty, there's a little add-on to that. So that sometimes people get confused. There's something called urgent community response, which is usually a therapy and care-based intervention to keep somebody at home, and those have been around for a while and are fabulous, and people running frailty virtual wards often are linked to them and they work very closely with them and often provide the multidisciplinary team sort of as a whole, but that on its own isn't a virtual ward. The virtual ward is looking after people who would be in hospital with senior clinical decision making and often, you know, point of care testing, so the sort of things that you would get in hospital. So that's the two places that people can get it muddled up, and it's a fluid thing. In some places people say, God almighty, this person would definitely be in hospital, and other people would go, well, no, I would never have sent that person to hospital. So it isn't you know, black or white, but on the whole I think it's the principles remain that the person is sick enough to be in hospital normally.
Just again, touching on that from a safety perspective, and that kind of, it's not black and white, how from a clinical point of view, can you just expand a little bit more on that, and how you manage that from a sort of frailty and a respiratory perspective?
I want me to go first to the frailty bit. So in terms of safety, I'm really comfortable at looking after really sick people at home, if that's what they want. And people have an opportunity in their lives to record what their wishes would be in the form of, you know, advanced directives or treatment escalation plans. You know, so if this happens, I want this to happen. So people will often have said, I don't want to go to hospital, no matter what. And when my time comes, I want to die peacefully at home. And so for those people, you know, you obviously confirm with them that that's what they want now. But then I feel confident to say, like, I can do this treatment. Is that what you want? And they can be really sick. And sometimes in the context of frailty, there will be lots of really bad things that you get, and you can make them better this time, and you can make them better the next time. But one of these times will be the time that you die. And if they want to die peacefully at home, then we have to provide that treatment at home. So in terms of safety, I'm really confident that if I've got the patient and the family with me and I'm doing what they want, I can do anything. And there is always the backup. You know, you can always call an ambulance and say, I've changed my mind. I actually want to go to hospital. So I think that in that sense, in the context of frailty anyway, that's what I do. But what do you say, Sarah?
I mean, I think hospitals are extremely important for people with respiratory disease, and there will always be people where hospital is absolutely the right place to be treated, because you need the ability to respond when people are deteriorating quickly. So some patients may need resuscitation, may need to be admitted to an intensive care unit. And so if somebody is sick enough to need those sorts of treatments, then they need to be in a hospital environment where they can get those treatments quickly, if that's what they want and is the right treatment for them. But for many patients, they aren't necessarily going to benefit from those treatments, and we send them to hospital because that's what we've always done. And there is an opportunity to think about doing things a little bit differently and thinking what can safely be provided at home. I think the key really is that we're thinking about safety. So we can advise patients what we think is the right treatment for them. We can advise where we think the best place for them to be cared for is to receive that treatment. But ultimately, it's up to them about what they would like us to do, because it's based upon what's important to them. So I think, provided you really explain to people what their options are and they're involved in the decision, I don't think you can go wrong. Unlike frailty, though, we do often have some parameters where we really say, you know, if for example, their sort of clinical observations, like their breathing rate is very high or oxygen levels are very low, we would very strongly recommend hospital admission. But for many people, you know, we can now give them treatment at home that, you know, we hadn't really thought about 5 years ago.
Brilliant.
I would like to add to that hospitals aren't always a very safe place. And in the current context where people are waiting a long time in corridors or in ED departments on trolleys or in chairs, that people can get worse very quickly in terms of their mobility. They can decompensate and decondition really, really quickly. So I've been absolutely gobsmacked how quickly people get back up off their feet if they stay at home, and how, you know, they don't need a massive increase in their care package and, you know, new Zimmer frames and what have you, because in their own home they keep getting up and going to their own toilet and reaching for their own drinks from their own bedside tables or next to the chair. And so it is, in that sense, there's a safety plus side of staying at home, which is really important for our patients.
I think you're right, Sheila, and I think it's really highlighted that during COVID, that whilst hospitals are fantastic in certain situations, they're also not safe places for everybody. So certainly during the COVID pandemic, lots of people didn't want to go to hospital because they were afraid they may catch COVID. But there are lots of other hospital-acquired infections that you really want to protect vulnerable people too, if you don't need to expose them to those things. And also, you know, you can easily get more confused if you moved out of your normal environment. As Sheila said, you start to lose your physical strength if you're not walking around doing normal daily activities. So hospitals are great when you really, really need to be in one, but they're not great if you've got an alternative.
Brilliant, thank you. What I wondered was, from a patient's perspective, what should they expect from a virtual ward? Again, you've touched on some of this, but I'm just thinking, what does it look like? What does it feel like to that patient?
You go first, Sarah.
So I was a little bit skeptical about virtual wards before I sort of moved into the virtual ward arena, because I think patients really like to know that there's somebody, a real human being, that's looking after them, and they know who that person is and they know how to contact people when they're worried. So I was worried that would be lost in virtual wards, but I've actually found the opposite. So this isn't about computers delivering care. This is about people being in their own home and being closely monitored by a healthcare professional who knows all about them, and they can call if they're worried. So I know some patients have described it as a bit like having a doctor or nurse on tap, because they know that somebody's watching them and monitoring them, and they also know they can call for help when needed. So from a practical perspective, most people on a respiratory virtual ward will have some equipment at home where they can measure their oxygen levels, their temperature, pulse and blood pressure on a daily basis, and also answer questions about how they're feeling. And they may or may not also have a telephone call with a nurse to check in on them on a daily basis as well. And then if there are problems, they can be visited face to face or advised to go back to hospital, or we can sometimes deal with the problems over the phone.
And so in the context of frailty, it's a bit different. So some frailty virtual wards do use the remote monitoring that you've just talked about, and we don't in our team at the moment. And ours is much more like a hospital at home. So we will we'll get our referrals from, say, a paramedic. That's our commonest referrer in our area, or primary care, or it's some of the community team. So that, you know, to say that care homes, we get lots of referrals from care homes. So to say, you know, that the patient is unwell, and then we will go and do an assessment which involves turning up with. We turn up with bags full of kit, because we have all the sort of so we do a clinical assessment, and then we'll do so examine them, and then we do point of care testing, so you can sort of set it up on on the kitchen table and get the blood test results within sort of 3 or 4 minutes. So you take your blood and that, and then you might, if you need oxygen, then we've got oxygen cylinders in the car, and if the patient needs intravenous antibiotics or intravenous fluids, then we'll set that up, and you usually hang it up on a picture frame hook. You take down a picture. This is the tips that I learned. You take down a picture and you use that hook, and sometimes you even hang the picture back up again. So it literally looks a bit like that the hospital has come in. A patient once said to me that I'm like Mary Poppins. I open up my bag and I pull out hospital, which I thought was really lovely. And so we do all that often. So people will often need things like pressure relieving equipment. They might need a short-term hospital bed because they're less mobile than they used to be and they're at risk of sores. They might need a new Zimmer frame. So those things we will bring as well, just as you would in a hospital. So it looks a bit more like that, and then we might then move into a more remote. So phoning them every day, they can always contact us. So and then sometimes we might need to go back and examine them again. It's not all infections. It can be heart failure, and it can be electrolyte abnormalities or new seizures, or all a gamut of all the things that can go wrong. So does that help? Do you think that gives a picture of what it looks like?
It sounds like it does to me. One of the things I wanted to ask, you've talked a lot about why a patient would want to be on a virtual ward. So just expanding on that and drawing on your experience of working with people, what from the people that you've worked with, what have you heard them say about why they've benefited being on a virtual ward from a patient's perspective?
Yeah, I mean, I think for people with underlying respiratory problems, it can be really frightening when you're acutely unwell. And some people feel safest in their own homes with their families around them and familiar things. And some people feel safer when they're in a hospital environment with healthcare professionals around them. So I think virtual wards are not for everybody, they're for some people. But for many people that would rather have their care at home, they feel much more reassured having the people that they care about around them, if that's possible. And also they recover much more quickly if they carry on looking after themselves, getting up to go to the toilet, being in charge of their own medications and staying a bit more mobile and active. So most people say, that they would rather be in their own home when they're unwell. But I have to emphasize it isn't for everybody. So this is a choice. This is something that we've got in our sort of array of choices now that we can offer to people. And you have to choose the right thing for the person depending upon what they want. But we've had really positive feedback about how well supported people feel in their own home. They really feel that it's like being in a hospital in terms of the sort of level of input from doctors and nurses remotely that they get.
Brilliant, thank you. Sheila, is there anything you want to add to that?
Yeah, I think like Sarah, we've had incredibly positive feedback, and the sort of comments you often get was, I was so frightened, that if he had to go to hospital, that he wouldn't come out, or that my wife gets so much more confused when she's in hospital, and so it's been great to have her staying at home. So those sorts of comments. I would say the only add-on to that is delirium is quite common in the context of being unwell in frailty, and probably is in some of your patients as well, Sarah. So getting more confused, and sometimes we put a lot of pressure on the carers. I have access to care and I have access to overnight care, but I don't always have it when I need it for our patients. And so sometimes families will often pull out all the stops to try and keep somebody at home, but you can put a lot of pressure on a carer by doing that, and sometimes you have to sort of say, are we doing the right thing here? Are we making you exhausted? So sometimes I think we just need to be really clear that although there are patients who would be better, sometimes we just can't provide the support that they would need, and we have no choice but to go to hospital. So I think we just need to bear that in mind as well. It can be tough. And also, you do literally bring a load of people and kit into somebody's house, and that's not for everybody either.
How do you manage? If somebody, talked about some people are anxious about going into hospital, but I can imagine some people are also anxious about remaining at home. Is there anything to say about how you manage that? What sort of conversations you have, and how that's kind of in your experience, how that's kind of worked generally?
Yeah, I mean, a lot of people with respiratory disease find the sensation of breathlessness really frightening. And sometimes if they can measure their own oxygen levels at home and know that they're safe and they're not in imminent danger, that can offer a level of reassurance. And also having the ability to pick up the phone and phone somebody if they're not feeling well, to know what to do next. Because although hospitals are fantastic, you don't have anybody standing by your bedside in a hospital either. So either way, you often have to call for help, and the help can come quite quickly, even when you're at home. And we can also, send clinicians out to the house or send paramedics if required, when people are acutely unwell. But it's a personal choice, I think.
I'd say exactly the same. If people are too worried about it, we sit down and we have a conversation, and if at the end of the day they say, I think I don't think it's for me, well, off you go. The only time we've had complaints, and we've had very, very, very few, has been when members of the family have disagreed. So some, so you usually can, we obviously go with what the patient says, and and the power of attorney and all that stuff. But sometimes some families are thinking, this is outrageous. How could you possibly keep my mum who's this sick at home? And so that's the so you do have to bring the family with you, and sometimes that's hard. But if you focus on what the patient wants, that's usually, I will say, you can't really go wrong.
Okay, so just finally, if you were to give sort of 3 top tips to people who are starting on this virtual ward journey or in the early stages, what would those top tips be from the learning that you've both had?
So I think some of mine would be that perfection is the enemy of progress. So you don't have to have perfect pathways before you start doing this. You have to make sure that you've got really safe pathways, and that you're going to manage people safely, and you're not going to do anything that puts them at additional risk. But sometimes just getting going helps clinicians to sort of learn about virtual wards, and also lets patients become familiar with the concept. So I would say it's better to get going than to think about it for too long. Having said that, everything takes longer than you think it's going to do as well. So IT seems to be one of our biggest problems, is that the NHS is not terribly joined up from an IT perspective. So just starting the thoughts early about who you'd want to share clinical information from, what clinical information you'd need to see in a virtual ward is really important, because making sure that all the healthcare professionals that a patient might come into contact with know what's going on is absolutely vital. And then I think my final top tip would be to sort of really listen to what people think and hear what their concerns are, because people have often got really valid concerns about why they are worried about virtual wards. And so if you listen to those concerns and try to think about what you can do to put things in place, you can often get success. It's been winning over the hearts and minds of clinicians who aren't familiar with virtual wards has been quite tough, I think, in some areas. And so really making sure everybody understands what it is and what it isn't, and what we can do and what we can't do, has been really important.
So 3. Okay, I'm going to go for number 1. Invest in advanced clinical practice. So there just aren't enough doctors to do this, and sometimes doctors are actually not the right people to be doing this. So I think I work with consultant advanced practitioners and trainee ATPs, and we've got 20 plus in our team now. And so you have to be prepared to invest in their training, just as you would if you were training nurses or doctors. But what the skills they bring it's like a sort of a super multidisciplinary team. So you come in with all, we've got dietitians and pharmacists and physios and nurses, and and they all come in, and then they get the skills to do the proper clinical assessments and diagnosing and prescribing, and you get a really strong, deep team that can do a lot. So I think really invest in advanced clinical practice. I'm convinced it's the way forward. I think my second one is a little bit like Sarah's, but in that I totally agree. You've just got to get going. You've just got to, just start, because there's too much talking, and you've got to get your 5,000 clinical governance ticks before you do anything. But if you're going to do that, I think in the context of frailty anyway, just buy your point of care testing. Just get in touch with your labs, get some point of care testing, and suddenly you'll realise that you can make really good clinical decisions at home when you've got some fairly basic blood results at your fingertips. And then my last one is the same as I've said all the way through, but if you do what the patient wants, you can't go wrong. So really base what you do on some really good patient preferences, treatment escalation plans, respect forms, whatever you call it, but base it on that, document it clearly, and you won't go wrong. You're on for a winner. And it is really rewarding. It's really fun to do.
Brilliant. Shelagh, Sarah, thank you so much for your time today. Your insights have been inspiring, informative, and certainly I've learned a lot from you both today. I'm sure our listeners and people watching the podcast will have too. So thank you very much. I'm certainly looking forward to seeing the next podcasts in these series, and I'm hoping all those that are watching this will do too. So thank you both so much. Thank you.